Welcome to the third in our series of looking at the classification of diabetes. This is the third episode in series 4 of Diabetes Health Matters, and my name is Dr. Joan St John. This webinar series is sponsored by Eli Lilly and Company and Menarini, although they have no input into the content of our webinar series. Dr. Jean-Claude Katte is our diabetes clinical researcher who is joining us again in this episode. He is sharing his expertise, having worked at the University of Exeter and also working at the National Obesity Centre in the Yaoundé University in Cameroon. In the 2 previous episodes, which you can find on our YouTube channel, we have spoken about type 1 diabetes, or what you thought you knew about type 1 diabetes, and the new things that Dr. Jean-Claude Katte has uncovered in his groundbreaking research. We've spoken about the umbrella term of type 2 diabetes and what may be expressed differently within that term of type 2 diabetes. So things like ketosis-prone diabetes, monogenic diabetes, and young people who are developing type 2 diabetes. And if you're uncertain about any of that, check out the YouTube channel and see those 2 previous episodes. This time, what are we going to be talking about? We're going to be talking about type 5 diabetes. Did you even know that there was a type 5 diabetes? We're going to be talking about type 3C diabetes and how that expresses itself and how that might be treated. We'll talk about gestational diabetes. So there's so much still for us to learn. Please stay active in the chat, ask lots and lots of questions. As you know, we'll have a Q&A as well, so you'll still be able to ask some more questions there. And I want to welcome Dr. Jean-Claude Katte and ask him, what's type 5 diabetes? This year, 2025, the International Diabetes Federation decided to look in more detail at type 5 diabetes. Now, I know for a number of people, they've never heard of type 5 diabetes. I mean, they're just getting their head around type 1 and type 2, and then we're coming now with another type 5, and there's a type 3, and there's a type 4, and there's other types, and so much to unpick. So, welcome, Dr. Jean-Claude. You know, we've got all these different types of diabetes. Why is it important?
Yes, that's a really good question. You know, when I went into medical school back in 2004, 12th of October 2004 was my very first day in school. And the textbooks we used back in those days, obviously, within the diabetes chapter, we had type 1 diabetes, type 2 diabetes. We had gestational diabetes and other forms of diabetes. So lots of other things. And now we're beginning to look at we've talked previously about the heterogeneity within type 1 diabetes, more so within type 2 diabetes. And now there are lots of other types or subtypes of diabetes that are being studied across the world. And now we are talking of type 5 diabetes. But what is most important is what will be the clinical implication for treatment, and does it matter for treatment for a patient? Why? Because if we have a new subtype that is treated differently or in a different way from current forms of treatment, that it is important to identify that subtype, especially from diagnosis, so that people who develop that subtype can be treated adequately from onset. So if it doesn't matter for treatment for the patient, then it's only exciting for science. But it's also important to note that, yes, understanding the different scientific mechanisms behind these subtypes would help us identify the true clinical entity and can help us shape treatment, and in some cases can help us tailor specific public health interventions. So that's why this discussion about types and subtypes are important in this era.
So, in terms of prevention, and in terms of treatment, and in terms of that individual. So, all of these different subtypes that we're talking about, these are the key things that we're really focused on. So, I would like to start 2 decades on from when you started medical school with this exciting International Diabetes Federation working group now going to look into type 5. Can we start with that? Because, as I say, a lot of people wouldn't even know that there is a type 5 diabetes. And what does that mean? What does it look like? Why is it important?
Yes, the story behind type 5 diabetes is quite interesting. And it may be interesting to know that I think the story started way back in 1955, somewhere in Jamaica, with the very first cases of what was then thought to be diabetes as a result of malnutrition. Now, that term went through a number of changes, and we have, it was picked up sometime in Africa in the 80s called tropical diabetes, tropical forms of diabetes. Later, we have studies showing diabetes linked to malnutrition in other areas of Africa, in East Africa, for example, in Ethiopia, and which led to the WHO back in 1985 to say that malnutrition-related diabetes was a unique entity of diabetes manifestation. But from the 1980s to the 1990s till about 2000, when I think there was a WHO classification that met a working group that met in 1999, they estimated that malnutrition-related diabetes was not a unique entity because there was not a flow of consistent report. Across the board, apart from the cases, the case reports that had been reported, in parts of the Caribbean, in Africa, and also in Asia. So malnutrition-related diabetes was, taken out of the diabetes classification. So, like when we started studying medicine back in the 2000s, it was just something of history as a young man that, malnutrition related. We knew it just like that, malnutrition related diabetes. But it's interesting that scientists working in Asia and also in the US, especially the group led by Professor Meredith Hawkins, who have been doing some work with colleagues in India, are finding out cases where it seems malnutrition is playing a very strong role in men, young men mostly, developing diabetes. And they've gone a long way to carry out some of the very initial studies published back in Diabetes Care, I think some 7 years ago, showing that the metabolic profiles of these males who are lean, very low BMI, developing diabetes with a very strong history of malnutrition is completely that the metabolic profile seems to be different from type 1 diabetes, and it seems to be different from overt type 2 diabetes. And so that work has led to other work, and then with the framing of a working group with IDF coming into play and putting together a formal working group to develop more research around this area, which obviously led to the announcement, which we all heard back in, I think, April from the IDF, formalizing that there is a type of diabetes now called type 5 diabetes.
And they're estimating that this could account for about 20 million people globally.
Yes, I think that's what we've read, in the literature, that this can be can be estimated to about 20 million people, which is non-negligible in itself, But now when I look at it I think there's a lot that has to be done in this area to really try and unpick this form of diabetes, because malnutrition at the moment, obviously it's a past diagnosis, right? You're picking people in their 20s and 30s, and you're trying to go back into their history and find out if they had chronic malnutrition. We know, at least from pathophysiology, how chronic malnutrition can affect the way the pancreas develops. So if you are, for example, if you had chronic malnutrition when you were in the uterus, when your mother was pregnant, we know that it would affect the way your organs develop. So you may develop smaller organs. And if you've got chronic malnutrition to the point where certain essential minerals were absent, such as calcium, zinc, manganese, which are very important to the development of the beta cell, then it may mean that your beta cell pool will be smaller. And, then that would lead to you, being born having probably a smaller pancreas, having a smaller beta cell pool, which means that you will not be able to secrete insulin like the rest of the people who never knew malnutrition in utero. So these are some of the ways that by which it is thought that chronic malnutrition, whether in utero or early infancy, can affect the way diabetes is manifested in middle age individuals.
So it is important to say it's a working group that has been set up. It is going to look into it more. Again, there's a lot of information that we don't have as yet, but they're going to look into it more, into the pathophysiology, into the clinical manifestations, obviously, hopefully prevention and treatment of this particular type of diabetes called type 5 diabetes. So you have to watch this space. And
yeah, really, I think it's exciting. It's exciting, and we all, myself included, watching the space. I've got colleagues who are on this working group from Africa, and so it will be interesting to see how our own African data sets can contribute to this global discussion on type 5 diabetes.
Amazing. So where should we go next? Because we've looked at type 1, we've looked at type 2, we've looked at type 5. There's a 3 and 4 there that we haven't addressed yet. Where should we go next?
Yes, it's interesting that the working group chose type 5, because I was asking myself the question, what about type 3 and what about type 4? But we already know that there are some entities, type 3, type 4, that are not formal, linked to the way whether insulin relates to, aging and brain. That's how people would talk about type 3 and then type 4, with regards to old age. But there is at least a unique entity of diabetes called type 3C diabetes, which is diabetes which results as a result of specific pancreatic disease. So in cases where individuals develop acute pancreatitis, but mostly chronic pancreatitis or pancreatic cancer. So this is diabetes that comes as a result of these pancreatic disorders or pancreatic diseases. So they are called type 3C diabetes or pancreatogenic diabetes. So this is a specific entity. And it is now known that, for example, a recent study from colleagues in the UK, in the US, and also colleagues from Exeter, from the University of Exeter, have shown that it seems to be very common, more common than we think, because most of these patients are diagnosed as having type 2 diabetes. And so, meanwhile, they've got type diabetes that is as a result of a specific pancreatic disease. And why is this important? Because if you develop diabetes as a result of a specific pancreatic disease, it means that for you to be treated optimally, you probably need apart from your usual diabetes treatment to control your blood glucose levels, you may need other replacement therapies due to the fact that other cells or other like from the exocrine compartment of the pancreas, because they would usually present with pancreatic insufficiency or exocrine insufficiency. So we may need to give back some of these components, so like pancreatic exocrine replacement therapy, because as we know from biology, the exocrine compartment contributes a lot to how we digest food globally. And so if that's not being replaced, they may end up developing some other form of malabsorption syndromes that would cause their diabetes to be worse than before. So that's why it's important to identify this type 3C diabetes. And how can you do that? It suffices to talk with your patient. I would say with the person living with diabetes. A good history. This can be common in people who have a history of alcoholism, because alcoholism, as we know, can lead to chronic pancreatitis. People who've got pancreatic cancer, and so the details in the history can help us. But also, when we examine, these people, we should think that a huge proportion of people who have type 2 may have type 3C.
Yeah, absolutely. And I think as a clinician, it's important as well, in that because of the damage to the pancreas, you may need to use insulin treatment as the effective treatment for that person living with type 3C diabetes. And as you said, in terms of the other functions that the pancreas does, because of it can cause malabsorption if other functions are affected, you need to give treatment for that as well. So it is important to identify type 3C diabetes if somebody is living with that, because the way that you would offer treatments and the treatments that you would offer are going to differ from if they were living with type 1 or type 2 in terms of the subtlety and the emphasis of those treatments that you would use. So you mentioned, and let's just mention a little bit, because people are thinking, okay, now we've got type 1, we've got type 2, and then all of a sudden we've gone to type 3C. So what are there other types of type 3 diabetes?
I mean, if you do a quick search, you would see people walking around type 3A, type 3B, but these are really non-entities per se. Type 3C is very specific, and as we've said, is grossly misdiagnosed within the type 2 diabetes population. And it's important because it means it can be treated differently, as we saw. But in terms of other types around type 3, no, type 4 really it's a non-clinical entity at the moment. There's some talk and there's some work around that area. Type 5, as we discussed, yes, there's already a working group set up to look more into type 5. But we have gestational diabetes, for example, which is a unique form of diabetes that affects, that it's gestational diabetes is diabetes diagnosed for the first time during a pregnancy, and usually it would disappear at the end of the pregnancy, and it's treated. It has to be treated because it has huge implications for the infant and for the mom. If not well treated and well controlled, during that pregnancy.
Yeah. So before we move on to speak about gestational, just briefly, so for completeness sake, so we have covered 1 to 5. Just briefly, type 4 diabetes is not a specific clinical entity, more of a research entity, would you say, where people have suggested that as people get older, they are leaner, so they're looking different to some of the other types that we've talked about, and they are feeling that this is what they've termed type 4 diabetes. And there may be a slightly different underlying pathophysiology.
Yes, that's I think where the work or the talk around that is at the moment. Uh, well, I would say, we talked about this, I don't know in what episode, that if all of us live long enough, we are going to develop diabetes, and most likely type 2 diabetes. So having said that, I think within that group, I think it would really be people developing type 2 diabetes, as a result of age. And we said that age is the most prominent risk factor for diabetes, and especially for type 2 diabetes, because as you age, the risk increases. So I think that's where the discussion is around type 4. Probably, as science evolves, if some, it can become unique in the sense where specific pathogenesis or physiopathology comes up within the next few years. Probably that's why the idea of working group decided not to touch type 4 and said, no, let's get to type 5 and leave that 4 group for people who are trying to look at the association between old age and diabetes, and if something is going to come up from there.
Okay, wonderful. So let's talk about gestational diabetes. So you said it's diabetes that occurs within pregnancy. So it's not a pre-existing living with diabetes. It's something that develops usually in the second or third, what we call trimester of pregnancy. So do you want to say a little bit more about that, and more specifically, how it affects the woman, the person who's pregnant, and also how it can affect the baby?
Oh, yes. So, yes, as we said before, gestational diabetes, hyperglycemia first discovered, during a pregnancy. And I think one of the key things that we can say from the onset about gestational diabetes is, as you move from different parts of the world, the way gestational diabetes is diagnosed differs. But we all, at least from all the classifications and all the working groups, they do agree that an oral glucose tolerance test should be done. And what is an oral glucose tolerance test? So an individual is actually given glucose at a specific grammage. So what is usually used is the 75 grams of glucose. You're given glucose to ingest. And so you take glucose, and then your blood glucose is measured, at the time before you take the glucose. So that's considered the fasting measurement. And then maybe 1 hour or 2 hours after the glucose intake. And so based on different classification systems, whether from WHO or from NICE in the UK or from other parts in the US, it is considered that you have gestational diabetes when this oral glucose tolerance test is performed usually between the 24th and the 28th weeks of pregnancy, and you have a high fasting above a certain threshold, or a higher 2-hour glucose above a certain threshold. I mean, as I said, depending on which classification you use, you would have different proportions of people, therefore, who would develop gestational diabetes. But across the board, it is considered, for example, in Europe, that about 1 in 6 live births, pregnant women would develop gestational diabetes, with an overall prevalence in Europe of about 6%. That the proportion is considered to be higher in other parts of the world. In Africa, for example, around 10%, in Southeast Asia, about 15%, in the Americas, between 6 and 11%. So the geographic distribution of gestational diabetes is quite varied. But some of the very key risk factors for gestational diabetes, therefore, would be having a family history of diabetes, but being overweight and being obese with pregnancy. It's a huge factor for developing gestational diabetes, but also having other chronic diseases like hypertension or other hypertensive diseases of pregnancy like preeclampsia, eclampsia. They increase your risk of you developing gestational diabetes.
And and also if you've had previous pregnancy with gestational diabetes. And I just want to signpost people to a previous episode of Diabetes Health Matters when we spoke about gestational diabetes. And what I want to move us on to talk about is, well, I'll say, if you develop gestational diabetes, so if you develop diabetes during pregnancy, your risk of developing type 2 diabetes subsequently in your life increases. So you're at increased risk of developing type 2 diabetes as time goes on. I want to ask you, Jean-Claude, how, if the person giving birth has type 2 diabetes or has diabetes during pregnancy, how that affects the baby.
Yes, I think the very first thing that clinicians are usually worried about babies during a gestational diabetes pregnancy is number one, the weight of the baby. Because during that pregnancy, it's not well treated and well controlled, which is why it has to be treated and well controlled. The baby may grow excessively large. And if the baby grows excessively large, then we are going to have issues with normal delivery or with the type of delivery that can be offered to delivery mode that can be offered to the lady. And so that would increase generally the proportion of surgical removal, so a cesarean section, maybe because of a large baby, and we don't want the baby to go out normally, then we have to do a cesarean section. And also in cases where normal deliveries are tried, then we have issues around shoulder
Dystocia.
Dystocia. Oh, trying to get the name in English. Shoulder dystocia, and all the other mechanical complications with regards of a large baby going through the pelvis. So those are some of the complications that can arise. And obviously, there's also, if the baby is growing large, the baby is being exposed to high rates of insulin coming from the mother, the risk of the baby being born and having hypoglycemia is there. So it's not negligible. It's something that we should watch for regarding the baby. Now, regarding the mother, of course, it's a two-way traffic, right? We have all the other chronic diseases that, like chronic diseases of hypertension, that can also be associated with gestational diabetes, and so making the quality of life, or impacting negatively the quality of life of the mother, but also the risk of going in for surgical delivery, the risk of because of course, surgical delivery or all the other mechanical complications obviously would increase the risk of maternal mortality. Unfortunately, it's something that probably less seen in the high income world or in Western societies, but that we still see, contributing to maternal mortality, unfortunately, in Africa and in other low income areas. But also, I forgot to mention about the baby, also increasing neonatal mortality also for the baby.
So gestational diabetes is something to take very, very seriously globally, and something that obviously we want to identify and obviously help the person to keep their blood glucose level as close to normal as possible for their own health and also for the baby's health as well. Absolutely fantastic, Dr. Katte. Once again, I think there's going to be so many questions because there's so many different types, and we've just thrown up more questions. So it's like if you thought you knew everything there was to know about all the different types of diabetes, there's so much that we don't yet know that we're discovering. So Be active in the chat, ask lots of questions, and we'll try our best to answer those. Thank you so much.
Thank you very much. Thank you, Joan, for having me again on Diabetes Health Matters.
Thank you, Joan, and thank you, Jean-Claude, for this excellent introduction to the topic. We've had a lot of questions in the chat, so please continue to comment and to introduce yourself if you're a healthcare professional. That's always useful to know. I'm going to go straight into the questions, and not in any particular order. George asked if type 5 has ever been diagnosed in the UK. Jean-Claude, can you answer that?
I think we said during the presentation, this is really work in progress. And I would say no, it's work in progress. I think there's really more to come in the type 5 space. And it's not, we said it clearly, you know, type 1, type 2 are really clear clinical entities with of very high clinical importance, especially on how they'll be treated. Type 5, I think it's a space to watch out for now, because more research has to come through.
Okay, it hasn't been diagnosed. It doesn't mean that there aren't anyone living with type 5. It's just that, as you said, it's very early, and it is possible some people in the UK are living with type 5. They just don't know. We need to and let the research and the group that's working on this topic to define more precisely the rules for diagnosis and treatment. Is that correct? This is what we're talking about today regarding type 5.
Yeah, so in terms of diagnostic criteria, in terms of the optimum treatment, that's what the working group is going to be working on. I think the important thing is that it's actually recognised that there needs to be a working group so that they can do this work and give us more information so that we will be able to find how we diagnose it, how we best treat it.
Excellent. Moving on to type 3C, there was it's a technical question, but I'll send it to you, Jean-Claude. It was with regard to the type 3C. Sukai asked, what if the damage has been made to the acinar cells? Might need to define acinar cells, or maybe Sukai could define it in the chat. Will these be diagnosed as type 3C or just type 2? Anyone inspired by this question?
So that's the reason why it's called type 3C in the first place, because as I said during the presentation, it's diabetes that results directly from pancreatic damage. That's why if you look at textbooks, they called it, pancreatogenic diabetes as well. So, and for that to happen, you would definitively have damage to both the exocrine part of the pancreas, which obviously is made up of acinar cells, and the endocrine parts of the pancreas, involving the beta cells that secrete insulin, which is why the person is going to develop diabetes in the first place. So yes, in type 3C, most likely you would have damage to the acinar cells, which are part of the exocrine compartment of the pancreas.
Thank you very much, Jean-Claude. We have other comments or questions, particularly with regard to the prevalence of type 5 diabetes in Africa, where there are potentially more people living with diabetes that have experienced malnutrition. As it stands today, the treatment for people that have been diagnosed with type 5 will be similar to closer to type 1 or type 2. I know that it's difficult to comment, but what will happen to these people currently as the working group is further refining this? Jean-Claude.
Yeah, that's really an interesting question. If you look at the studies from which
on which the working group is, basing their discourse on. As I said in the presentation, this is usually diagnosed in young males, and who have some form of insulin or relative insulin deficiency. It is true that in type 2 diabetes as well, we have some form of relative insulin deficiency. But at least the studies have shown that the insulin deficiency is higher in individuals who present with this form that is currently being alluded as type 5 diabetes. So they may need some insulin, treatment, just like any other person with, type 2 diabetes once in their lifetime may have to use insulin for optimal control. Now, whether other therapies, such as metformin and other oral glucose lowering agents would be used, we don't know. I think we really need to wait for research to point the way in this area, whether, metformin, glimepiride, and or other therapies would be useful for them or not. But if you do, for example, an insulin or C-peptide test, which is the best test to do. We talked about it in other episodes, and it shows that they have really low C-peptide levels, then you would definitely want to put someone on insulin treatment at that point. It is usually advised to want to do a C-peptide, usually after 3 to 5 years from diabetes diagnosis. And that information can help you tailor whether you use insulin in a particular person or not.
Mm-hmm. Thank you. Joan, did you want to add anything on this topic? Because we have another question coming up on type 5. I'll move on to other topics as well.
Okay, no, just very briefly to add, as Jean-Claude has said, it's almost is like a retrospective diagnosis currently. If the person had undernutrition, I prefer, rather than malnutrition, undernutrition, then they are more likely to be developing this type 5 diabetes. And I think I just have to flag up again, it's a working group that's been set up by the World Health Organization. So we also will be learning more as that working group reports.
And that sort of answers the question that Barbara was asking. Are there any recommended sources for more information on type 5 diabetes? Where would you go for this information, Jean-Claude, as of today?
I think it depends on who is looking for that information. If it's a person living with diabetes or a scientist like me, because the depth of information that I want obviously will be different. So type 5, go to the IDF website, for example. I think what you would find is just, the working group that has just been set up. If you are a clinician, scientist interested in more research, I don't know how, but I don't know if they have to contact, but there are specific papers that I can send to someone who is very interested and wants to know more about the research in that area. There's actually a very beautiful, I would say, review paper that came out probably about 2 weeks ago on the topic. And it's still, as I said, it's still really new. Some scientists still think it's very controversial. And so I would not really want us to want to over-label ourselves on it for now, because a lot is yet to be done in the area.
Thank you very much. Sorry, my screen is a little bit slow because I was also trying to share some information as I was listening to this, Jean-Claude. I wanted to say to everyone, you've just said that you were happy to share information, Jean-Claude, as usual. I wanted to say, if anyone in the UK wants to meet with Jean-Claude, Jean-Claude will be at the Diabetes Africa 2025 forum that we're organizing in November. So if you are a healthcare professional and you want to get in contact with people who are passionate about advancing diabetes care for Black populations and you are in the UK, please join us and visit diabetesafrica.org to register for our UK forum. So that's it. My bit is done. I wanted to go back to gestational diabetes. A question was, what are the targets, blood glucose targets for gestational diabetes? Now, I wanted to, I know part of the answer, but I'll leave the experts to comment. They're actually tighter than the targets outside of pregnancy. Like, who wants to take this question? I mean, obviously, it will depend on individuals, but Joan, did you want to comment on this?
I will always add a proviso that I can't give individual advice, because this is a webinar with lots of different people on it. So it's generic information that we give. The targets are always going to be individualized to that individual as to what the blood glucose levels should be. But as you said, Greg, they are certainly tighter than they would be if you were living with, let's say, type 2 diabetes. And the reason for that is the reasons that Jean-Claude outlined previously. In terms of maternal health, in terms of the baby's health, the tighter the blood glucose level is, the closer it is to normal, the less risk there is for the mother and for the baby, and for a healthy pregnancy and for a healthy delivery as well. So it will vary depending on where you are in the world, but we can say in general terms it's going to be tighter than it will be for somebody who is living with type 2 diabetes, let's say, as a long-term condition.
And another follow-up question on this, the children of mothers who had gestational diabetes, do they have a higher risk of developing type 2 at a much younger age? Who wants to take this question? Jean-Claude, you're nodding, so that's a yes, I want to take this question, I assume.
My nodding was just a direct answer to say yes. Yes, there's evidence for that now, that children who were born from both mothers who develop type 2 diabetes, mothers with type 2 diabetes, and from a pregnancy that was linked, that was, a gestational diabetes pregnancy, in those offsprings, there is an increased risk for type 2 diabetes as a result of an increase in insulin resistance. So the pathways that are affected towards the development of diabetes, it's pathways around insulin sensitivity or insulin resistance that is increasing those offsprings.
Can I also add that there is some evidence, I believe, Jean-Claude, you can confirm whether this is the case or not, that if the father has a type of diabetes, there is an increased risk of the child developing diabetes, usually type 2 diabetes, in the future as well. Whether not necessarily at a young age, but developing it. Yeah.
Thank you, right. Joan. Jean-Claude, sorry, did you want to add something?
No, I said correct.
Correct. That's a very broad question with regard, we were in the chat, there were discussions about the preparation for pregnancy. If you are living with diabetes, if you're a woman living with diabetes and you need to prepare for pregnancy, there are certain things you need to do, particularly take 5 milligram folic acid, check for teratogenic medication, and have your HbA1c and other metabolic factors under control. But Joan, do you know why only Black, so the question is not exactly correct, and we will correct it in the chat, but Black women are the least likely to be well prepared for pregnancy. What do you think are the reasons for that?
I think there are multiple reasons. I think, okay, we could do a whole episode on this. Let me start with the health service. The health service is a service to the people that it serves. So if Black women, African Caribbean heritage women are living with diabetes, type 1 or type 2, of an age whereby they may be considering having a pregnancy, then it is down to us as healthcare professionals to ensure that these women are informed of what is going to give them the best chances of a healthy pregnancy, healthy delivery, healthy baby. So that's one thing. So we as healthcare professionals have a responsibility. We as an organization, Diabetes Africa, other organizations want to raise awareness for people who are living with diabetes so that they themselves know what they need to do. And that's really, really important so that the person's personal responsibility is there, but we as healthcare professionals have a responsibility as well. And then the wider health service and health systems have a responsibility. So we could do a whole episode on why this is the case and what we can do to address it. It's one of the issues that we deal with within our healthcare professionals advancing equity in diabetes care conference, which is coming up. But I think that I'll leave it there because I know there are lots of other questions, but it's vitally important because we want to ensure healthy pregnancies, healthy mothers, healthy babies, healthy deliveries.
Thank you, Joan. And I will quote you to say, each one teach one, which is something
Each
that
one teach one. Absolutely.
you have been repeating over and over again in this series of Diabetes Health Matters. And every contact counts. Now that you have this information, you can pass it on to others. And that's the reason why we are organizing these events. Thank you, Joan. A very clear and straightforward question from Clara, an advanced nurse practitioner in diabetes. So her question is, when we're talking about all these different types, in which group can we place new onset of diabetes after total pancreatectomy? Know that. Jean-Claude. Can you help us put all these diabetes in the right boxes?
I think that there are two things here. I would answer it from the standpoint. So if that person developed diabetes as a result of a pancreatic disease before the pancreatectomy, then that would be classified naturally as type 3C diabetes. For example, if that person had chronic pancreatitis or a pancreatic cancer that led to total pancreatectomy. Now, if total pancreatectomy is as a result of another cause, for example, road traffic accident and with laceration of the pancreas, and then the pancreas had to be removed totally, for example, you would naturally expect that person to have diabetes after the surgery. So where would you classify that one, Clara? So yeah, so it's diabetes as a result of total pancreatectomy. So what I'm trying to say is that for so those can be put under other specific types of diabetes. If you look at textbooks, some classifications talk about other specific types of diabetes. So yes.
Thank you very much. And it just shows how the role of clinicians is changing with regard to diabetes. There needs to be more caution. Did you want to comment on this, Joan? How, because you are working with people living with diabetes on a daily basis. So all of these nuances about diabetes, about different types and subtypes, as a clinician, how do you approach this?
So I would say, first of all, I really liked the highlighting every contact counts, because as healthcare professionals, it doesn't matter where you sit in the health system. We all have a responsibility of service to the people we're working with, sometimes called patients. So I would say that, Greg, I've forgotten your question because it was so important to me, that every contact must count. Give me your question again, sorry.
Well, how do you approach your role of as a
Right.
clinician with regard to diabetes? Now, knowing that there are all these different subtypes, what does it change in your practice on a daily basis?
Okay, so I think it's vitally important to get the diagnosis right. When the change of diagnosis or the absolute classification of that diagnosis is going to alter the way that that person you recommend or advise or work with someone to see the best treatment for them. So it's really important in that respect. Jean-Claude has made mention sometimes of the scientific um, help that is important to make certain classifications and certain diagnoses as a sort of scientific exercise. As a clinician, it's important to get the right clinical diagnosis so that you can offer the right treatment and help that person to get their blood glucose levels down. So in that respect, yes, it is important, but for some of the classifications, it's less important.
Jean-Claude, did you want to comment on the importance of getting the diagnosis right? Why is it so important, Jean-Claude?
Yes, getting the diagnosis right, especially from diagnosis, is important because we know that when diabetes is well treated from onset, there is a carryover effect of good glucose control from onset that can last in some instances for 5 10 years. What is termed a legacy effect. So that's why it's important to get it right from onset. But it's also important to say that at times it may be difficult to get it right from the onset, and that may require both the person living with diabetes and their doctor and nurses and other clinicians to journey with the person and to observe correctly and tailor the treatment, because today we have a huge arsenal of therapeutic options, and tailor the right therapy that would lead to good glucose control and a good, because it's not only about glucose control, right? For therapy, there's also things that has to do with the quality of life of the person living with diabetes. So there's a lot of armories that we have now in our hands as clinicians to do the right thing for the person living with diabetes. But there really has to be a good understanding and a good relationship between the pair.
Thank you, Jean-Claude. And we've said it at the beginning, but I encourage people in the room who haven't participated or haven't joined or seen the previous episodes on type 2 and type 1 to watch these episodes on YouTube, on our channel, to know better the different forms of diabetes. Dr. Joan, I wanted to add something to this because getting the diagnosis right is also important from the point of view of the person living with diabetes. If someone see their diagnosis change, that has an impact, I guess, on mental health, on how this person feel. Do you want to comment on this? Because we have spoken with many people living with diabetes who, particularly who have been diagnosed with ketosis-prone type 2 diabetes, and the diagnosis has changed between type 1, type 2, and for them it is a journey that can be very difficult, Dr. Joan.
It can be very difficult, and also it can shake the confidence of that person within not necessarily the clinician as an individual, but within the whole health system. And I think that's why I say it's a collaborative thing to do. It is not about a sort of patriarchal way of working with someone. It has to be a relationship so that you can say the diagnosis can evolve. there are specific tests that we can do which can give us an indication of what type of diabetes the person may be living with, but sometimes it is not clear cut at the beginning. It can be subtle, it can be nuanced, it can evolve. But I think if you share that information with somebody is more likely to have confidence in you as a healthcare professional for being upfront and honest with them, rather than saying categorically it's this and then changing later to say categorically it's not that, it's something else. So that therapeutic relationship is so important between healthcare professional and the person living with the condition.
Thank you, Joan. If you are on your laptop tonight, you should have seen a poll pop up on your screen. Please take a moment to let us know whether you've learned anything during the event series that you can use in your practice as healthcare professional, or I suppose if you're living also with diabetes, if that's changed something for you. And if you are on your mobile phone, you may have to swipe for right or left to find that poll. So we're very interested to have to hear your views on this question and others. So while we continue to, we'll ask a few more questions before closing this episode, but do have a look at the polls and let us know how this episode has impacted you. So we have covered quite a broad range of topics. I'm just checking the chat if there are any questions that we have left unanswered. Please correct me if there's something that's important, Joan or Jean-Claude. Do put your questions in the chat. We will make this episode available online on our YouTube channel. The question, Jean-Claude, with regard to the types that we've discussed, are they can they be put into remission? Do we know that? What is the when we look at various types of diabetes? What can you say? What comment can you give to that?
Well, I would say that there is evidence that we can put type 2 diabetes into remission. And I think that's there is, we have today enough evidence for that. If your diabetes is as a result of a particular disease, for example, there are other things that can happen on someone who develop diabetes. We've talked about chronic pancreatitis. If chronic pancreatitis is treated properly in such a way that there is limited or no injury to but the endocrine, or limited injury to the endocrine compartment of the pancreas, then I believe there's some room, if that is treated properly, for that person's blood glucose to go into to go back to being normal, which we may call remission, for example. I don't think, I've not seen data specifically on that per se in type 3C diabetes. If your diabetes is as a result of, let's say, Cushing's disease or Cushing syndrome, and if that is well taken care of in itself, then we would normally expect that once that other disease is well treated, then your blood glucose levels would normally go back to normal. Some people, for example, when we had the COVID pandemic, COVID-19 pandemic to be precise, many people who were diagnosed with with COVID at the time of diagnosis also presented with hyperglycemia and received a diagnosis of diabetes, for example. And after that initial episode, their blood glucose went back to normal. So these are things that can happen. But I was just giving other examples, but I would end by saying, with regards to specific diabetes types, type 2 diabetes, especially close to diabetes diagnosis, there is enough evidence to show that people having type 2 diabetes can go into remission, even up to reversal.
Yes, thank you, Jean-Claude. And we understand that obviously research is ongoing on the new types that we discussed today. And so it is difficult to give a definitive answer, particularly as we discussed the type 5 is just under investigation by this working group. Dr. Joan, did you want to add something to what Jean-Claude has said?
No, that's fine. I was just going to try and find the review article. Was it the one in Global Health, Jean-Claude?
Yes, there is the one in global health, and there is I can just let me get there is a recent very argumentative review that came out on the type 5 issue. Let me get it rapidly.
Okay.
Yep. I can get it and put it in the chat.
Excellent. In the meantime, please do have a look at the polls. We're running some polls to know more about you and your background, where you're coming from, and the next question will be about our future events. We're coming to the end of this episode. I'm going through the questions. We have covered quite a few. I don't know whether we have the time for rapid fire questions. There were questions about the type, just to clarify, I see, is this classification validated, and has the IDF supported this classification? Jean-Claude, just can you reassure us about what we are talking about today and who is behind this classification?
I think, am I muted or not? Can you hear me?
No, you're okay.
Yes, yeah.
You're okay.
All right. Obviously, it came from the IDF, right? I guess the IDF would not put something up if it's not been vetted. And probably that person is asking that question with regards to, I don't know if they've read some of the counter arguments that individuals have written to the IDF, why they felt that it was a bit, I would say, premature. Well, as I said, it's still a very controversial issue scientifically. And I would say, let's just watch the space and see what will develop in the next few years to come.
Thanks. And we'll probably then have you again on Diabetes Health Matters to update us on this topic. And everyone who is in the room, please follow us and subscribe to the YouTube channel, subscribe to our newsletter, because we will continue to investigate these topics and bring you the information. Dr. Joan, it is time for us to close the episode. Thank you so much for all your questions. We haven't been able to answer everything. I think we have please try to do our best. Dr. Joan, first, I give you the floor.
Thank you very much. So I want to say a massive thank you, first of all, to Dr. Jean-Claude Katte for his wonderful experience, knowledge, insight into type 1 to 5, controversial as it may be, in giving us all this information about the various classifications, the different types of diabetes. It's been absolutely phenomenal, really, to have you as a guest for these past 3 episodes. And also I can see from the engagement, from the questions, from the global reach. It's absolutely wonderful, Jean-Claude, and I just want to say a huge thank you to you. I want to say a huge thank you also to Diabetes Africa, Mr. Diabetes Africa, who's been asking the questions today, but the whole team who've done such a wonderful and great professional job of producing this series of Diabetes Health Matters. Big shout out to all healthcare professionals, from all over the world. Come to London, Wednesday, the 26th of November. Book quickly for our Advancing Equity in Diabetes Care for Black populations. But as you can see, when we talk about for Black populations, it is for all populations, because what we want to do is raise the quality of care that is provided and make sure there is no inequity. So don't forget, each contact counts. Make it count. Each one, teach one. And please stay tuned, come back, join us for more episodes of Diabetes Health Matters, where hopefully we'll continue to learn together, because the chat has been on fire, if I can say that. this evening. People swapping information, asking lots of questions. We're so grateful to you. We learn together. Thank you, everyone, and have an excellent evening. Once again, thank you, Diabetes Africa. Thank you, Jean-Claude. Really appreciate it.